It's really wonderful to be here with all of you today. I'm so grateful for all of your hospitality and really excited to talk with you about bladder cancer in older adults and some of the work that I did during my GEMSTAR award. So these are my disclosures. I think my biggest disclosure here is that, my parents and my in-laws are older adults themselves, and my dad is actually a prostate cancer survivor. These are our objectives for today. I'm going to talk a little bit about how bladder cancer is a really burdensome chronic condition in older adults. We're going to talk a little bit about the concept of treatment burden and go over some of my recent work on bladder cancer, and then talk about maybe some future directions and some conclusions. So these are my parents, my two favorite baby boomers. The reality is that we're all going to be caring for older adults with cancer. And 2030 is a really important year for all of us because the 73 million strong baby boomers will all be over 65 by 2030. So we're going to be seeing a lot of these patients in our practices. And cancer is very much a condition of aging. The incidence of cancer increases with age. And this is some data from SEER Medicare and the American Cancer Society showing that about 2/3 of new cancer diagnoses are going to be in older adults age 65 and older. And actually, the peak incidence of new cancer diagnoses is in the 8th decade of life. And it is the second leading cause of death in individuals over 85. And just looking at the curves here for incidence in men, about 13% of those new diagnoses are in prostate cancer and about 13% are in bladder cancer. So urologic cancers, which are my primary clinical focus, are really important in that age group. So this is just some more statistics about what we're going to be seeing in terms of increases in genitourinary cancers over the next 7 years or so. By 2030, we're going to see a 71% increase in prostate cancer, 68% increase in bladder cancer, and a 67% increase in kidney cancer. And all three of those cancers are in the top 10 in the United States. So just kind of honing down more specifically on bladder cancer very much specifically affects older adults. It has the highest median age at diagnosis of all cancer sites. The peak age at diagnosis is over 80. You see 179 new cases per 100,000 in that age group. Bladder cancer staging, I'll just go over a little bit about that. About 75% of new bladder cancer diagnoses are what we call non-muscle invasive bladder cancer. And looking at this little diagram of a bladder, there's a red line there between T1 and T2. So T2 is the more invasive kind. That's 25% of new cancer diagnoses. Those are treated with about 3 to 4 months of chemotherapy, followed by major surgery to remove the bladder and other organs, and major reconstruction of the urinary tract. However, the most common bladder cancer we're seeing are non-muscle invasive, so they're just superficial in the lining of the bladder. And those are typically treated with a pretty rigorous course of scraping of the bladder wall to get the tumor out, and then follow-up cystoscopies to monitor for recurrence, and also treatments into the bladder with medications. We are seeing rising incidence of non-muscle invasive bladder cancer, in particular in older adults. Non-muscle invasive bladder cancer is an extremely burdensome chronic condition. So even though most older adults don't tend to die of this early stage non-muscle invasive disease, it does have a very high recurrence rate, between 30 and 70%. And it actually has the highest recurrence rate of all cancer sites. And so as a result of this high recurrence rate, these patients have to come in frequently to have their bladders monitored with cystoscopy, which is an invasive procedure in which we stick a scope in the bladder. And they also have to undergo intravesical treatments where we actually put medication directly into the bladder through a catheter. These recurrences are treated, as I mentioned, with surgery, and these patients require general anesthesia. Well, we're not making incisions on their bodies. There's still a high-risk population that's undergoing a so-called low-risk procedure under general anesthesia. And this is our American Urological Association risk stratification scheme for non-muscle invasive bladder cancer. We see low risk, intermediate, and high risk. And by risk, we mean what is the risk of recurrence or progression to more invasive disease. And you can see how rigorous this treatment course can be for patients, especially in intermediate and high risk disease, that they may need up to 19 visits to urology just to treat in the first year. And that doesn't include imaging, tests, surgery, preoperative appointments, path discussions, ER visits, etc. So that is what the idealized guidelines tell us we should be doing for every patient. But what I see in my clinics is really different from what the idealized guidelines say. So this is a very typical patient that I may see in my clinic. So an older adult, 85, with visible blood in his urine, which led to the diagnosis of a large tumor in their bladder, falling into that high-risk category where he would need to undergo 19 visits in the year after diagnosis. He has multiple coexisting chronic conditions and is on blood thinners, has multiple medications, and sees at least 5 different medical specialists to treat all of his other chronic conditions. Comes in a wheelchair, he's tired looking, and comes with his son who's working full time. And they're both exhausted and overwhelmed by this new diagnosis. And what I think about when I see this is, how are we going to handle the situation? And I was seeing this over and over again in my early practice. I come out of fellowship and I think, hey, I'm going to follow all the guidelines. I'm going to cure cancer. We're going to do this. But this is a different situation. And in talking with these patients, their goals aren't necessarily to cure cancer. Their goal may be to manage symptoms so that they can enjoy other things in their lives or not be spending all of their lives going to the doctor. And so these are some things that my patients have said to me over the years about managing their bladder cancer, talking about, do they still need to come in for surveillance, or can they just come in if they're symptomatic? Trying to figure out what to do with their coexisting conditions, because some of their treatments may actually cause their other conditions to be exacerbated, or thinking about quality of life versus quantity. How many treatments are we going to do to them? Each time the treatment causes them significant side effects, and they're shuttling back and forth between the hospital and home. So, and this is another frequent thing I hear from my patients, is that it feels like they spend their whole life going to the doctor, and it's not just that little 10-minute visit in which I'm seeing them. It's getting ready, it's coming in, it's waiting because I'm always running late. It's, it's all of those things accumulate. So I really started to dig into this, and I wanted to understand better the experiences of my patients and what we could do to try to help them. And so as I was learning about this, I came across this concept of treatment burden. And treatment burden is defined as the work of being a patient and how it impacts a patient's functioning and well-being. In this concept has been studied quite extensively in multimorbidity and multiple chronic conditions. And in diseases like diabetes or COPD, it has been associated with care adherence and quality of life. But few studies have really looked at aging and cancer. And the way I like to think about treatment burden is that it's this constant tension between all of the workload that we're throwing at these patients and their families, and what resources they have to accomplish that workload and successfully. And if they're not able to accomplish the workload successfully, it can lead to disease exacerbations. They can have difficulty adhering to the care plans, and then that leads to different outcomes like hospitalizations or functional decline. And then it can be a feedback loop where it comes back and they have even more workload as a result, and perhaps fewer resources to handle it. So I I wrote a grant to try to understand treatment burden in my non-muscle invasive bladder cancer patients. And our study had three aims. One was to look in a national data set to understand treatment burden in terms of healthcare utilization. Our second aim was to understand the direct patient experience of how an accumulation of aging-related deficits could be associated with treatment burden. And then the third aim was to look at how in older adults, deficit accumulation could be associated with strain in the caregiver and to understand their experience. So I'm just going to talk a little bit about aim 1 and aim 2. Our caregiver work, we are still in process of analyzing that data. So I'll just kind of go over what we learned in our first two aims. So our first aim was to look at a national data set. And so we wanted to try to understand how different geriatric or aging-related conditions were associated with healthcare utilization in the year following diagnosis of bladder cancer. And so we had a cohort of over 70,000 patients from the SEER Medicare database, which we obtained from the National Cancer Institute. We had 13 years of data from 2001 to 2014. We specifically looked at non-muscle invasive bladder cancer, so we focused on HACC stage less than 2 at diagnosis. We looked at older adults who were 66 and older at the time of diagnosis. And the reason we chose 66 was so we could have a 1-year look back period at their claims to determine their baseline geriatric conditions. And they needed to be enrolled in Medicare Part A and B. Our primary outcome was treatment burden, and we measured this as a count outcome of health system contact days in the 12 months following the diagnosis. So we looked at outpatient visits, ED visits, the number of days hospitalized, and that was a total not just related to their bladder cancer care. Well, we did do a separate analysis looking specifically at their bladder cancer care as well. And I think there is a limitation to thinking about treatment burden as just a number of, as just healthcare utilization, which is part of the reason why we looked at the patient experience as well, because treatment is so much more than just what we're seeing in the clinics. So we chose some specific geriatric conditions to look at. We based it on a guideline that's published by the American Society of Clinical Oncology. These are geriatric conditions that they recommend evaluating at the time of diagnosis of cancer and prior to initiating cancer treatment. We also looked at incontinence because that's a big issue for our bladder cancer patients and a major side effect of treatment. And this is just a summary of our design. So we looked at the baseline geriatric conditions using ICD-9 codes into those different buckets of the aging-related conditions. We then we looked at everything from a year prior to diagnosis. Then they had their diagnosis, and then we looked at, in the year following diagnosis, how many health system contacts they had. And we controlled for a lot of different covariates as well. And we did a negative binomial regression model for this. So we found that geriatric conditions were very common in this population. So we looked at functional dependency using the Furrow scale, which is a probability of how of functional dependency. We found that almost 40%, a little over 40%, had intermediate or high probability of functional dependency. Multimorbidity was extremely common in this population. We see that a lot with our bladder cancer patients. And then the other conditions you can see here as well. In terms of results, we found in our overall cohort that they were spending on average, for an average patient in our cohort, approximately 9 days engaged with the health system. We found differences between our rural and urban patients. We found that our rural patients were engaged in health system contact for more days than urban. We saw the largest effect size for multimorbidity. So here you can see 11 days on average for a patient in this cohort. And we saw that for every single chronic condition or every single aging-related condition, there was a higher adjusted mean days if they had the condition. Except for dementia, we actually saw that there was less health system contact in the year following diagnosis in patients with dementia. So then we looked at, how does multimorbidity impact healthcare utilization and treatment burden? And we found that for each additional chronic condition that a patient had, they had a 13% increase odds of health system contact. And you can see this graph where with each chronic condition, and this is just multimorbidity patients, with each chronic condition that they had, each additional one, the amount of health system contact they had went up. And you can see, for somebody with 15 chronic conditions, they had almost 40 days of health system contact. And then we were really interested in the differences between our rural and urban patients in this cohort as well. And so we looked at, for the counts of chronic conditions, was there a difference between the rural and urban? And we found that rural patients tended to have more health system contact, more treatment burden compared to urban. And that was true for almost every additional count of chronic condition. So conclusions from our AIM-1 were that having a geriatric condition was associated with higher treatment burden following non-muscle invasive bladder cancer diagnosis. We found that multimorbidity and rurality had the largest effect sizes, and that each additional chronic condition conferred a 13% increased odds of health system contact. So the more medically complex an older adult was, the more treatment burden they experienced. Interventions, we believe that interventions may be needed to reduce the treatment burden for these patients, especially in rural areas. So then, looking at healthcare utilization was one way to think about treatment burden, but we also wanted to understand what the patient's experience of treatment burden was. And so we conducted a cross-sectional survey study for our AIM-2. And this was a mixed methods evaluation, and we used a validated survey tool for treatment burden called a treatment burden questionnaire, and then evaluate the association with geriatric conditions. So we were able to recruit during COVID 119 older adults with non-muscle invasive bladder cancer. We wanted to get a range of experiences. So we tried to recruit patients who had non-muscle invasive bladder cancer for at least 6 months so that they could have experienced some of the treatment. Our primary outcome was the treatment burden questionnaire score. And the treatment burden questionnaire is a 15-item questionnaire that each item has a 10-point Likert scale. The range of scores is 0 to 150. It's just a simple summation, and higher scores indicate more treatment burden. And our exposure was the deficit accumulation index, which was derived from a geriatric assessment that was mostly self-administered. We also looked at urinary symptoms because just in talking with my patients, a lot of them reported that the side effects from their bladder cancer treatment was very burdensome to them. And so we wanted to look at whether there was an association between the urinary symptoms as well. Just a little bit more about the deficit accumulation index. So the deficit accumulation index we use is based on the deficit accumulation model of frailty, where each additional aging-related deficit contributes to overall frailty. We used a special geriatric assessment tool from the Cancer and Aging Research Group. It's mostly self-reported. It takes about 27 minutes for patients to complete. Most of them can complete it on their own. And it has been validated specifically for older adults with cancer. And it also covers all of those ASCO guideline geriatric conditions that I had shown before. You can see the equation here. You basically count up the number of deficits and divide by the number of potential deficits, which was 75 potential deficits from this tool. And it can either be considered as a continuous variable from 0 to 1 or as a categorical variable with cutoffs for robust, pre-frail, and frail. So this was just a summary of our AIM-2 design. So we identified 119 patients. We gave them the geriatric assessment tool and the treatment burden questionnaire, and then we evaluated the association between the geriatric assessment and the treatment burden questionnaire. These are just some of the characteristics of our enrolled older adults, and we found that they had quite a few other geriatric conditions. So multimorbidity, again, rose to the top here. 87% of our patients had 2 or more chronic conditions self-reported, and many of them had weight loss, almost a quarter, falls, and almost a quarter had more than 5 prescribed medications. Looking at the categories from the deficit accumulation index, we found that actually a significant portion of our patients were pre-frail or frail, almost 44%. And on the average DAI was 0.21, so they were overall tended to be in the pre-frail category. These are just the distributions of our outcome and our exposure. And actually, we were kind of surprised to find that so many patients reported that they had no treatment burden, 31 of our cohorts. And then, of course, we had some outliers, that were reporting, 80 on the 0 to 150 scale. I think it was instructive for me to think about, sometimes, engaging in treatment for cancer may not feel like a burden for some of our patients because they're doing things to help cure their cancer. I mean, there are different perceptions about what's burdensome and what's not. So this is just a list of all the questions in the treatment burden questionnaire. It covers a lot of different things outside of just healthcare utilization. So, number of times you're taking medications, arranging transportation to and from appointments, financial burdens, et cetera. And the things that were most commonly flagged by our patients were the frequency of lab tests and other exams, the frequency of doctor's visits, financial burdens. This was a primarily high school educated rural population that had some low health literacy and were an underserved population. And the need for medical care reminds them of their health problems. So the last question in the TBQ is a global measure of treatment burden, which is that is it something that is involved in your everyday life, and 66% reported that it was. So these are the results from our multivariable modeling. We used a technique called lasso, which allowed us in a small cohort of 119 patients to think about a lot of different variables. And so we, in lasso, will pick out what is most significant out of all of those variables. And what we found is that the DAI and the UDI-6 were most significantly associated with the TBQ scores. And we found that for each 0.01 increase in the deficit accumulation index, the treatment burden questionnaire score increased by 3%. And for each 1 unit increase in the UDI-6 score, the TBQ also increased by 1%. I think I'm still trying to understand what is the clinical significance of these increases, but I think it is helpful to think about it as units of increase, that as we're seeing more deficits accumulate, as we're seeing more urinary symptoms, that treatment burden perception does go up. So as I mentioned, this was a mixed methods analysis, and we asked our patients also about what their greatest challenges were with managing their medical care. We conducted a directed content analysis of their written responses to that question, and we initially started coding it using the treatment burden questionnaire score domains. And then we also allowed for open coding for additional themes. And interestingly, what we found is that there were differences in what was most burdensome to patients who were pre-frail and frail and those who were robust. It seemed that our robust participants were more concerned about cancer worry and the side effects from their cancer treatments, and also spending a lot of time at appointments. Whereas the pre-frail and frail had more concerns related to self-management at home. A lot of it was finding products for leakage or dealing with a catheter at home, or dealing with urination bother, which was also a major side effect of those treatments into the bladder and multiple bladder surgeries. And I think our main conclusion coming from this project was that as these aging-related conditions accumulate in quantity and severity, our older adults with non-muscle invasive bladder cancer experience greater burdens related to cancer treatment. They also have greater burdens due to side effects and their overall healthcare management, not just related to the cancer. We also found that our pre-frail and frail older adults had different specific burdens, and that's something that we should think about when we see these frailer older adults in our clinics, that they may be managing other things as well. And I think, urinary symptoms, I think this was very, interesting as well, that the urinary symptoms contribute to patient-reported treatment burden as well. So I think all of this has been really, really interesting for me and actually very hypothesis generating. And, I think the next steps that we're thinking about are really understanding some of the mechanistic, from a mechanistic standpoint, what is going on with the deficit accumulation and the treatment burden. Is it the deficit accumulation that's leading to the treatment burden, or does the treatment burden feed back into the deficit accumulation? And, how does this change longitudinally as health status changes, as, there are more and more recurrences? I think it would be helpful for me to understand, how treatment burden impacts care adherence and outcomes, because I think that can also play into decision-making for our older adults. I think we need to try to better understand our patients' preferences and align their care with their goals and health status. And I think this is an area where the 4Ms framework and age-friendly care can really play a role. I'm really excited about our AIM-3 as well, because I think our caregivers are such an important piece of this puzzle, since they help to manage so much of the treatment burden and what we throw at them as healthcare providers. And they're such an important part of our care team. So I hope to maybe report back on that in the future. And I think there's a real question here about rural health equity, knowing that our rural patients tend to have more healthcare utilization. They're dealing with longer transport times. Their burdens may be different, and we need to approach that. These are my in-laws. They're also awesome older adults in their 70s, live in Texas. So just some final thoughts and conclusions from this work. I think treatment burden is an emerging concept. It's an important patient-centered concept that we need to think about both clinically and from a research standpoint. I think multimorbidity and accumulating aging-related deficits and urinary symptoms are associated with treatment burden in non-muscle invasive bladder cancer. Understanding where a patient or what a patient's frailty is can impact what kind of burdens they're experiencing. And as healthcare providers, I think we need to be tuned into that. And rural residents may potentially confer greater treatment burden in our older adults with bladder cancer. I am really grateful to an incredible team of people. I think it takes a village to raise a junior faculty. I have some wonderful mentors and an incredible research team that I work with. I'm really grateful to NIA for being interested in bladder cancer. Both Geisinger, where I did this work prior to coming to Penn State, as well as my department at Penn State. And most importantly, my bladder cancer patients and caregivers were really just so enthusiastic about engaging with our team and sharing their experiences. So thank you.
Thank you so much for such an outstanding presentation. I learned so much, and I love the way you summarized everything at the end, and especially thinking about where you're going to go in the future with some of this. So thank you so much. I'm thinking that I saw a couple chat questions.
Yeah,
So Jenny,
absolutely.
maybe you can kind of start with those.
I did see.
Lika, we're going to have you stand up there to respond to questions so people can hear you well.
No problem at all.
Okay.
So Sarah Songer just had a couple questions. She asked if you could define what rural kind of parameters were in your research, and then if you have any clients who withdrew from treatment due to treatment burden.
Yeah. So for rural, we used the definitions that were provided in SEER Medicare. So they use, I believe it was county level RUCA codes. So we just applied the county level RUCA codes to our patients in the cohort. For our cohort from AIM-2, where we were recruiting patients, we actually used census tract level RUCA codes. And so we tried to, and our rural definitions are definitely not perfect, but we tried to drill down as closely as possible to where they were living. In terms of clients who withdrew from treatment due to the burden, so in our cross-sectional study, we did not look at that specifically, but just from my clinical experience, a lot of this work is spurred from one particular patient interaction I had where my patient was diagnosed with bladder cancer, and it was just like that story that I had told earlier about the 85-year-old, and he shortly after I diagnosed him, he had a massive heart attack and developed heart failure. And just even coming to a clinic appointment was exhausting for him. Just getting up on the table for his cystoscopy was exhausting. And we had a lot of discussions around whether it made sense for him to continue to come in. And we finally decided that he was just going to, focus on his heart disease. And we decided to basically stop doing anything additional for his bladder cancer. And he unfortunately, passed away a few months later, and it was all heart disease related. So yeah, that's the one that really sticks out in my mind always, because that sort of got me started on this road.
Not knowing a lot about bladder cancer, like what is the bladder cancer trajectory for your typical older adult diagnosis with non? So
Yes.
I apologize, but
yeah, I'll repeat. Yes. Yes. The question was, what's the trajectory for an older adult who's diagnosed with bladder cancer? So for non-muscle invasive bladder cancer, really depends on their stage and grade and which risk category they fall into. So, if they're low risk, their chance of recurrence is about 30%. So they'll come in for a couple cystoscopy visits. We don't do any additional treatments into the bladder for them. They're just on surveillance. And so, it's kind of variable. Some of them never have another recurrence and they do fine. And then after their first year, they just come in once a year and have a scope, and it's really not a big deal. for the intermediate and high risk patients, they can recur frequently, and they may, for intermediate risk, it's about 50%. For high risk, it's about 70% risk of recurrence. And so they may be coming in frequently. They may have, another recurrence within a year or two, and then we're taking them back to the operating room to, do another resection, and then doing another round of treatments, and, and then, we're kind of going back and forth. And I think they, particularly for our frailer older adults, that's when they get really tired of going back and forth and doing, coming in for weekly treatments and then, quarterly scopes.
I saw a question, at least one from Light.
Absolutely.
Might be more than one.
Here, let me read it out loud here, make it a little bigger. Light asked, are there technological advancements or innovation aimed at reducing treatment burden specifically for older adults with bladder cancer? And secondly, are there societal or healthcare system factors contributing to the treatment burden for older adults with bladder cancer?
Yeah, so I don't think we have any technological advancements or innovations right now aimed at reducing treatment burden. I actually am a little bit worried that the treatment burden is going to get worse in the coming years. There's a lot of actually technological advancements and innovations in treatments for non-muscle invasive bladder cancer, and actually very expensive treatments coming through. So immunotherapy has been approved for certain cases of non-muscle invasive bladder cancer, specifically, patients who have recurring disease that hasn't been responsive to intravesical therapy. So now we're talking about giving systemic IV therapy that has side effects to these patients. There's a lot of new additional different types of treatments for intravesical therapies that I think are also, that have the potential to have other like new and different side effects. So I am concerned about how these new treatments are going to impact our older adults. And I also, financial burden was a big one. Bladder cancer is actually the most expensive cancer to treat from diagnosis to death. And so now we're adding additional financial burden on our patients and families. And I think the story is being written as we're traveling on this path. And then as far as societal and healthcare system factors, I think the big one that I always think about is this care fragmentation, where we don't, a lot of our patients don't really have a quarterback who's running their care. So when I think about taking somebody to the operating room, I'm trying to understand, well, what medications do I hold for surgery? Is it okay for them to come off their blood thinner, or are they going to have a stroke from their atrial fibrillation? What's their chance? Are they going to survive anesthesia, even for a low risk procedure? And sometimes trying to get everybody together to talk about, how we're going to manage these coexisting issues can be really challenging. And I think that care fragmentation is where really, like, from a health system standpoint, is where it comes in, and trying to find a way to coordinate that care better and navigate it, I think would be really helpful. And I think would take a lot of the burden off of patients and families from, well, I have to talk to this doctor, I have to talk to this doctor. Why don't you all talk to each other? It's, I hear that a lot.
First of all, thank you. That was a wonderful presentation, methodologically and relevance. It's really clear that your work is a representation of your passion for care. So patient-centered. I really appreciate that. So my question is, could you talk a little bit about your plan for the cohort study and what the design that will be?
Yeah. So Dr. Boltz asked about my plans for the cohort study and what the design might look like. So this is still formulating in my head. But what I would love to do is, think about enrolling patients from a couple different sites. I've been thinking about whether I want to focus on rural patients specifically. And I would love to catch them at the time of their initial diagnosis when they're 65 and older, and then do some geriatric assessments using our existing tools, and then measure their treatment burden, and then follow them over time, different time points. And I would love to look at how do the trajectories change over time of each of those? How are they interrelated to each other? And then I would also love to look at how changes in treatment burden and deficit accumulation may impact their care adherence or their decisions to modify their treatment. And see if we can find, like, where is the kind of the switch point where that decision starts to occur. Because I think that would be really helpful for clinicians in talking with patients about, okay, at what point do we start tailoring care, because it's just too much and has limited benefit.
So there's no way to do a retrospective.
I don't think so. It's always been my dream to do a longitudinal cohort study. I do. Yeah.
Olivia, did you?
I really enjoyed listening to your presentation, and mine goes off of this technology question. I was interested in kind of treatment burden related to doctor's visits and appointments, and I know there was a rise in telehealth over the pandemic. So I was curious, did some of those visits, were some of those looked at as telehealth, or if not, I'm not as familiar with the area, so I don't know if telehealth is common, but do you think telehealth visits, especially in rural areas where you have to set up transportation, and there are those long appointment wait times, has the potential to reduce treatment burden, or there's some challenges associated with that?
Yeah. So Olivia's question was about whether telehealth could be implemented to reduce treatment burden, and whether that was looked at in our study. So it's a great question, because we literally did all of our recruitment during COVID, and so there was a big transition in our clinical care from in-person to virtual over the course of our study. And unfortunately, we weren't able to really drill down into like the healthcare utilization, and whether it was virtual versus in person. The one downside of non-muscle invasive bladder cancer treatment and surveillance is that it really needs to be in person, because we're doing office procedures for cystoscopy. We're giving them treatments into the bladder. It's very sort of human resource intensive. So, I think there are some people who are looking at like telecystoscopy for rural patients, where cystoscopy can be done perhaps by like an advanced practice provider. And then there's a faculty like at a academic medical center, or who's like watching the cystoscopy as it's happening and it's being transmitted. And if so that there can be some real-time feedback on, is there something going on? And there's a training program for the advanced practice provider. And urology is a huge shortage profession. So, this is something that may be really relevant, going forward as well for rural areas. So that's maybe one way where technology and innovation could sort of reduce the burdens of going to a central location where there are urologists to do these procedures, to incorporate telehealth. I personally have loved doing telehealth with my older adults, just to even go over, biopsy results, pathology results. I think it's just been wonderful. My patients love it. I will say that for our older adults, sometimes they really like video visits are really tough. Sometimes they don't have broadband access. Sometimes they don't have a device, or they're relying on their adult children to facilitate that visit. But telephone visits have been a godsend for that population as well, because at least we can, connect and talk in a way that's a lot easier and more convenient for them. There's I'm like dreading when the government decides to not pay for telephone visits anymore, because there's a big push for that. But I think that's going to be disastrous for my practice, actually, because it's been really valuable. So sorry, this is kind of a long answer to your question.
Well, and I'm going to sneak up here to, first of all, let people know whether they're in person or via Zoom, that Dr. Garg is going to hang around for a little bit longer. If you have other questions, or if you'd like to engage in discussion and learn more, you're welcome to stay. Again, whether that's in person or online, we'll keep Jenny's laptop going. But on behalf of myself, Dr. Donna Fick, who did have to leave for another appointment, and our whole CGNE leadership team, including our students, and most importantly, our students, we want to thank you so much. There's some goodies in this bag, but thank you so much for a wonderful seminar. I'm sure we all learned so much and gave us so many things to think about. As a reminder to participants, Jenny will put the link to the evaluation tool in the chat, so you can complete the survey now, or it will come to you via email within 24 hours. Please try to complete that within the week of the seminar. And then again, if you've met all the requirements in terms of attendance, time frame, completing the evaluation, you will receive contact hour certification within a month. If you have any questions, please reach out to CGNE at psu.edu. And thank you to everyone for participating today. Fabulous.